Right, so hi, yes, I'm Susie Bash. I think I've met most of you in the room here. So today we're going to be talking about AI-powered quantitative MRI, NeuroQuant in particular, and how it's really impacting and transforming radiology. So I'm a neuroradiologist at RadNet, and I'm also Chief Medical Officer of Cortex. So quantitative volumetric imaging, or QMRI, identifies and labels anatomic structures and then quantifies the volume of those brain structures and compares that to a large age and gender matched normative database. And that allows us to have a volumetric tracking to assess for rate of change over time. This is what the segmentation looks like here. And so all the pertinent substructures of the brain are segmented. And the reason why this is appealing is it really improves diagnostic value. It decreases reader subjectivity. Our referrers really don't like it when one neuroradiologist says, moderate atrophy commensurate with age, and then our colleague comes in just a couple weeks later for whatever reason the patient gets imaging, and now it's moderately severe atrophy with a temporal parietal predilection, and which is kind of telling our referrers, oh, that's a kind of a red flag maybe for Alzheimer's disease. So is it normal or is it not? And so again, this kind of software is very useful. It's also negligible cost to acquisition speed. So for dementia, it's just a 3D T1 input. And when we do MS, it's preferably a 3D flare, although the software does take 2D flare. But it really doesn't cost any extra time. So even for MS, if you use it, you can, instead of acquiring two separate acquisitions in the sagittal and axial plane, you just do your 3D flare and then reformat. So that's a great thing. No external hardware is required. This is all cloud-based, and it really integrates seamlessly and quickly into PACS. So these reports are generated back in less than 6 minutes. So before the neuroradiologist will ever see it, it's already done, and the report's waiting on PACS. And then really no radiology post-processing, and it offers a big referral advantage. We have found that once our referrers start using NeuroQuant, they don't stop. And I've actually been using NeuroQuant in my clinical practice at RadNet for the last 19 years, about 19 years. But again, I've never had a single referrer that stopped once they started using it. So they really do see value, and they will keep sending their patients back to your imaging enterprise, if you can offer this as a tool. So we can use NeuroQuant for multiple different clinical indications: dementia, multiple sclerosis, epilepsy, pediatrics, traumatic brain injury, and oncology. I would say by far our biggest use cases are for dementia and multiple sclerosis. So at least where I live in Southern California, every single time a patient has memory loss or MS, they're definitely ordering NeuroQuant with it as well. So we've seen a big increase in, this happens to be sort of RadNet data, but we've seen a big increase in our NeuroQuant volumes over the past year. They've gone up 103%. So we did 14,300 cases. Our MRI brain volumes have also gone up by about 19%, and you probably are seeing the same thing as well at Penn and other places. And then, of course, our amyloid PET volume has just skyrocketed. So we're at 5,200. So we're doing about 588 amyloid PETs. And, so I think probably one of the biggest reasons for these increase in volume is because of the rapidly changing dynamic in the Alzheimer's landscape, for dementia landscape. So again, our referrers are finding a lot of value, and I'll talk a little bit about why NeuroQuant is particularly important in the age of disease-modifying therapy. Now, we changed our order forms here when patients have memory loss so that we know if the patient if we're doing the baseline MRI or if we're doing an ARIA surveillance MRI. So ARIA stands for amyloid-related imaging abnormalities, and it's a risk when you're on disease-modifying therapy, but we need to know which one it is when we're interpreting, because our style is going to be totally different about how we do it. And then we have a separate click box here for quantitative volumetric imaging. So when the referrer orders it, they can just click what the clinical indication is so that the correct report is generated. And we also actually have click boxes here for the amyloid PET as well. So the exciting news is in January of this year, we then had new CPT3 codes for quantitative volumetrics, and it really became very important. First of all, these are vendor neutral, but it became very important for us to bill correctly under these new codes. And we want to try to facilitate a conversion from CPT3 to CPT1 codes in the future. But the great news is we're actually now starting to get reimbursed. So that was, we really almost didn't expect it until we had a CPT-1 conversion, but the MACs, RadNet actually petitioned all the MACs throughout the US, and they recognized the value of this tool. And so right now, all of the Western states are all being actively reimbursed. And then RadNet will petition again these MACs along the Eastern Seaboard and the Midwest, and they'll follow suit. So really the difficult hurdle was really the first MACs that started reimbursing. So if you are, and it varies a little bit by region, but if you're inpatient, you're going to get about $231 every single time a referrer orders a NeuroQuant. And then an outpatient like us at RadNet, we're getting $220, and we are definitely getting reimbursed. So that's really, really exciting news, and it makes a huge difference in ROI for imaging enterprises. Okay, so then, yeah. And so like, for example, we did 14,300. If we were to do the same number next year at RadNet, you know, at our projected rate of 220, I mean, we're looking at 3.2 million profitability. So not only does using NeuroQuant add a tremendous amount of value, but it's also worth it in a financial reimbursement sense as well. So let's take a look at how we use this. This is actually a patient of mine who was an 81-year-old woman with memory loss, and her Alzheimer's disease was confirmed by LP. Most people all get amyloid PET now, but before we started getting reimbursement, some people would get the LP. And this is what her baseline MRI looked like prior to starting Leqembi, and it looked really good. And then this is her baseline SWI, and she had one baseline microhemorrhage. And then she came in January prior to her 5th Leqembi dose, and you can see here that she started to develop ARIA. So this is edema here in the brain. She had just very mild headache and visual disturbance, but she really didn't even mention it to the doctor. It wasn't until the doctor went and asked her, she mentioned, oh yeah, just a little. So they suspended her dose, and she actually didn't just have ARIA-E, but she had ARIA-H as well. So these are 4 new incident microhemorrhages. This is the GRE here. Here's the SWI. By the way, this TE is too low. Please make sure your imaging enterprises have your TE. For a 3 Tesla scanner, it should be at least 20, and for a 1.5, it should be at least, I'm sorry, for a 3T, it needs to be 20. For a 1.5, it needs to be 30. And if it's too low like this, you will miss the microhemorrhages. So again, very important to have the correct protocol. Our referrers, like I said, do order NeuroQuant for anyone with memory loss. So NeuroQuant was ordered. And you can see here that this is the dementia report here, where we're looking at pertinent substructures. So the hippocampi, the entorhinal cortex, all these are pertinent towards patients with memory loss. And then we do the lobar cortical volumes as well. And in more advanced patients, you can use this to help differentiate between Alzheimer's versus frontotemporal dementia or dementia with Lewy bodies. And also additional structures are listed here when you're looking for sort of clusters of red boxes. Anything in red here is more than 2 standard deviations from the mean. Same here, if you're in the pink zone, you're more than 2 standard deviations from the mean. And then these numbers will also will turn red if you're more than 2 standard deviations. So what you see here is a patient that we know already has Alzheimer's disease, but relatively well-preserved brain volumes. This is actually really important because NeuroQuant took on a new role, a new significance now that DMTs are available, because you can essentially use this as a subclinical biomarker for disease state when they start treatment. So what you really want in an ideal situation is someone has a positive amyloid PET. You want preserved brain volume, because what we know from the Clarity AD trial for Leqembi, that 76% of patients have no cognitive decline, and actually 60% have cognitive improvement if you catch them in the very earliest stage of disease, which means the low tau state. Now, since we're not really being actively reimbursed for tau PET, we can use NeuroQuant to help assess how far along the patient is, because once tau starts accumulating, you start losing brain volume. So again, taking on a new significance here. And this means that this patient, the neurologist can go back and say, you know, you actually would be an ideal candidate for treatment and probably much better cognitive outcome since we're catching you so early. But unfortunately, this patient did actually have a witnessed seizure, and so it was brought to the hospital. And you can see here that the ARIA-E has progressed, and sometimes it really does progress. Now, ARIA-E essentially always resolves within a year, but it often gets worse before it gets better. So here is her MRI obtained 5 days after the seizure. You see the ARIA-E has definitely progressed. The microhemorrhages had stayed stable since the month prior. but that was a result of her ARIA-H. So here's the January study, here's the February study. So this patient has moderate ARIA-E because their largest is less than 10 was 10 centimeters, or I'm sorry, was 8.3 centimeters, I believe, but she's multifocal. Once you're multifocal, you're automatically in the moderate category, and then she's mild category for ARIA-H because she has 4 new incident microhemorrhages over the baseline microhemorrhage. So the great news is in August of this year, Cortex received FDA clearance for its 5.0 version, which allows us to essentially monitor ARIA. So it detects microhemorrhages and superficial siderosis, and also segments ARIA-E, so edema and sulcal effusions. So that is very exciting. So here again is her January study and her February study. And this, we're applying the automated NeuroQuant ARIA product here, and it color segments the area of ARIA, a beautiful, nice depiction. Here, it also will measure the largest size of the lesion for you. Here's the 4 new incident microhemorrhages and automated segmentation here, where the software picked up those microhemorrhages. And then this is what the report looks like. So here's a NeuroQuant ARIA-E report, the ARIA-H report. Again, your maximal diameter, the sites of involvement, and the overall lesion volume and the change since the prior study, and a correct grading here of moderate ARIA-E. And then this is the the plot graph here of baseline over the 2 MRIs that we had. And this is ARIA-H here, where here's the microhemorrhages plotted, and here's superficial siderosis, which the patient actually didn't have. And then it denotes here 1 baseline microhemorrhage, 4 new, with a radiographic category of mild. So you can see how this software would be very useful, not only for experienced neuroradiologists, but also people that are starting out their career. It's a lot to sort of remember the grading scale. And this software will process both off the GRE or the SWI, but keeping in mind that the grading scale was based on the GRE. That's what they used in the clinical trial. So like at RadNet, we do require a GRE for all of our dementia protocols, even though we know sensitivity is higher with SWI. And if the referrer really wants SWI, we'll do that in addition. It just can make your report a little bit more muddied if you're trying to report the SWI and the GRE and then grading off the GRE. So that's how we do it at RadNet. And that's what that looks like. This is just a close-up look of this ARIA-E here, so mild, moderate, and so sort of color gradations here, and it plots it for you. And then fortunately, this patient actually, her ARIA-E resolved. This patient actually couldn't wait to get back on the Leqembi, and she's doing great. Her cognitive scores have improved since she's been on treatment, so a good outcome, at least at this point in time. But the bottom line is manual ARIA screening can be time-consuming and difficult. In one study here, 84% of local radiologists initially missed it on MRI, and there's a lot of inter-reader variability. But yet an accurate MRI interpretation for ARIA is really critical because it directly impacts therapy decisions. So we actually polled, I'm on the ARIA leadership for American Society of Neuroradiology. We polled all of our 6,000 members, and the majority of the respondent polls did say that they were interested in using automated software for ARIA surveillance. Now, we don't typically use CT for dementia, but Cortex has a CT product, and it will auto-align images and then segment the ventricles here, and then apply automated subtraction maps. So here's the difference between the current and prior, and you can see how this would be useful for patients that have that have dementia, and also be useful for normal pressure hydrocephalus. Now, another big indication is in multiple sclerosis. We encourage, really all of our referrers to use this. Again, every time a referrer starts using us, they really won't stop. It's just so useful. So color-coded segmentation of the plaques according to the region of the brain, leukocortical, periventricular, infratentorial, and deep white matter. And then, most importantly, the dynamic lesion segmentation. So anything that's new or enlarging in size is a sort of a reddish, orangish color, and anything that's decreasing in size is a blue color. And you can see if the patient only has just a couple of plaques, you probably don't need quantitative software. But by the time we see, all these patients get annual follow-up, and they all end up in sort of the moderate or severe category. And it's just so much easier to pick it up when you use quant software. Computers are much better at pattern recognition than humans, although, of course, humans are better at global reasoning. But you can see how this software is extremely useful. This is just the individual plaque color coding here. This is the NeuroQuant MS report here. And I'm going to magnify this so you can see it a little easier, but it gives the current lesion burden here in centimeters cubed versus the prior. This is what our referring neurologists really want to know. If they see a big jump here, they're going to switch the disease-modifying therapy. So this is, again, why they find it so important. I tend to rely much more on volumes than on lesion count, just because if two plaques are adjacent to each other and then they enlarge, they can become confluent and counted as one instead of two. So again, I rely primarily on the volume, but I do use the count for the new enlarging or shrinking plaques, and I also report the volume as well. So again, extremely useful for longitudinal analysis. Now, this is the second page of the report, and it gives more detailed information about, asymmetries and burden elsewhere. I don't really include all this in my report, but it's there for your referring neurologist if they want to use it. So it's a very complete report, and also tracking the volumes. Some referrers like to know about the thalamic change and also the gray matter volume change. So that's there and available if you want it. There's also a pre-populated reporting template that summarizes everything for you. And so this can actually be auto-generated into your PowerScribe or whatever you're using to dictate, or you can copy and paste it, or you don't have to use it if you don't want to. But it's very nice and actually can impact efficiency, which I'll talk about in a second here. So the segmentation of the lesions has dramatically improved in the years since I've been using it. We now incorporate deep learning in addition to machine learning. And you can see here and we're now on version 5, but you can see here now these little plaques here in the pons were picked up. So again, really amazing evolution of the software that I've seen. So Cortex is doing a great job of making sure that the segmentation is accurate. And it turns out if you try to read these MS patients without software, on average, you'll call 24% disease activity. If you actually use a quantitative post-processing, that will jump up to 76%. And again, this makes a huge difference to our referring neurologists. And it also improves reliability of reading. So 22% improvement in intra-reader variability and 23% improvement of inter-reader variability. And then the big thing is it enhances productivity. Neuroradiologists want to add value, but they don't. Most of us are paid on an RVU basis, and so it can't cost time. And so in MS, it actually can save time. So in this study here, the neuroradiologist could read 8 studies an hour without quantitative software, and 13 when they use quantitative software with that pre-populated reporting template that I showed you. So this is very exciting because it can really help us go faster. Now, quant can be used in epilepsy as well. I like this example because you see here that the left hippocampal volume was within normal limits and the right hippocampal volume was within normal limits, but the asymmetry index was actually abnormal. And so this could make you think that this may be an emerging early, mesiotemporal sclerosis case. So when it's obvious, it's obvious. But a lot of cases, it's very hard to detect subtle changes, asymmetries, because of differences in slice sampling and head angulation. So again, this software can be very useful here. It can be used in pediatrics, to look at the different structures of the brain and for sort of longitudinal analysis. And again, one of the advantages is Cortex in normative age population goes all the way down to the age of 3. You'll see in the competitors, there's no pediatric application because their normative database doesn't go this low. And then it can be used for traumatic brain injury as well, where, basically calculating the areas of atrophy or that you see with post-traumatic cortical encephalomalacia or gliosis and how that impacts brain volume, and even with edema as well. And then it can be used in neuro-oncology. So, here's a patient that had a GBM. It's almost impossible often for us as neuroradiologists to differentiate what is pseudoprogression versus real tumor progression sometimes. And so using quantitative software is a wonderful tool. As far as I know, NeuroQuant is the only one that has an FDA-approved brain tumor segmentation product. So here's a pseudoprogression. We have some nodular enhancing tissue. But NeuroQuant brain actually does restricted spectrum imaging. And you can see here it's sort of a high-level diffusion, and it's negative here. And here's the perfusion that's also negative to match. And then here in this true progression, we have some nodular enhancing tissue, light bulb hot on RSI and that match perfusion. So very useful there. This is what the tumor segmentation looks like. And here's the RSI overlay and then the T1 post-contrast. and this is preoperatively and preoperatively after segmentation. This is the central necrotic core, the surrounding zone of nodular enhancing tissue, and then around that, the surrounding zone of flare hyperintensity. And this is post-op, and it will segment the resection cavity for you. And again, the red is the nodular enhancing tissue, and then the yellow is the surrounding zone of flare hyperintensity. And then this is all plotted for you here, so you can track your enhancing tissue over time and whole lesion volume over time. You notice the whole lesion volume, the resection cavity is excluded from that. So the red's the enhancing tissue, the necrotic core, and the surrounding non-enhancing flare hyperintensity. So here's another look here at segmentation and what this looks like. And then again, pre-op and post-op segmentation. So extremely useful. And so this basically segments for high-grade gliomas and low-grade gliomas, but we're developing out for meningiomas and metastases. So stay tuned for Q1 of 2025. Again, meningiomas are a dime a dozen for us as neuroradiologists, and can be very difficult to measure accurately, particularly along the skull base when they grow in all kinds of different directions. We don't even really know the best place to place the caliper, and really these should be volumes. In the future, everything will be volumetric measurements, and just much more useful. I mean, we can't even go on the measurements of our previous colleague when they read the prior study. We have to remeasure the prior because that's how hard it is to get an accurate measurement. So again, volumes are the way to go. And then also NeuroQuant has a vascular disease product. They're the only quant company that I'm aware of that has a vascular disease report here, and it will calculate the flare hyperintense burden. This is basically everyone over the age of 60. We all have some microvascular ischemic disease. It will actually auto-calculate the Physika score for you, and depending on your change over time, people's physicians may want to modify their blood pressure treatment or how aggressive they're going to get with their cholesterol. So again, a very useful report, helping to move these quantitative tools into standard of care. And this is just a closer look up here at the flare, and at this report. And eventually we'll also incorporate infarcts as well. And now that we have the capability, we can actually look for cerebral amyloid angiopathy and quantify the number of microbleeds too. Now, you can actually use NeuroQuant in addition to other AI tools like deep learning for image reconstruction, which in my opinion was really the first AI tool that has become standard of care. There's no reason why anyone shouldn't be using this. But basically what you do is you accelerate your protocols and then you apply deep learning. There's vendor neutral solutions like Subtle, and then all the OEMs now have deep learning as well, GE, Philips, Siemens, whatever. And then you denoise with the deep learning to bring back up the resolution and also, denoise the image to enhance the signal to noise and contrast to noise ratio. And so the question is the deep learning in some way altering the images, or how robust is NeuroQuant, when you apply it at two different acquisition points? So we looked at this in this study here that was published in the AJNR. There's a standard image on the left. This is you accelerated your protocol to go half. This is 60% faster. And then you enhance that fast image to denoise it here. So these are two separate acquisitions, and we applied NeuroQuant to both acquisitions. And you can see that the top row looks exactly like the bottom row because the volumetric segmentation matched for both standard of care and for that fast DL, which shows you how robust the NeuroQuant tool is. So whatever the hippocampal volumes were before, they were the same on a separate acquisition. So again, a very, very robust tool and really exciting technology. But overall, it really improves diagnostic value. It decreases reader subjectivity. As we talked about, negligible cost to acquisition speed, no radiology post-processing, and very easy to interpret. And then again, offers a referral advantage. So that's kind of a quick overview of some of the products. If you come back tomorrow, you'll hear more about the brain tumor. But that's kind of, it really, like I said, I think that in the future, really everyone will be using this kind of, and really I feel like the people that aren't using it probably just don't really know that this software is available. So part of what I'm doing as a big educational initiative is to, help people understand that this is available, it's commercially available, and now we can get paid for it. So that's wonderful. Does anyone have any questions about any of the products?
Very well explained.
Thank you.
Great job, Susie. Let's give her a round of applause.